So, gynec first session, we will complete anatomy, physiology, the basics, this puberty, menopause, and any abnormality with puberty, okay, and development. So, all these we'll finish it up in first session itself now. Anatomy, okay. First, let's run through the anatomy. This we know. This is the relations of all the organs, okay, to uterus and cervix. So uterus, cervix, and vagina will be here, and then in front will be the bladder, and the back will be the rectum, okay. And we have rectouterine pouch. That is, okay, rectouterine pouch is the cul-de-sac that yesterday we were speaking, okay, cul-de-sac, or it is pouch of Douglas, okay. And then there is going to be a utrovesical pouch. So these two are the peritoneal reflections that is actually present in front of the uterus and back of the uterus. Understood? And then deep below there is a conglomerate of the muscles, perineal muscles, which is going to be perineal body. Okay. Yes. So what is this? So anatomy, if we see, this is the uterus. This is a laparoscopic view. This is the uterus. Okay. This one is ovaries. This is fallopian tube. Okay, this is fallopian tube. That is the ones which are actually at the sides. Okay, that is fallopian tubes. But what is this? The one which is actually anchoring behind. That is going to be uterosacral ligaments. Okay, uterosacral ligaments. And what is this part? This part which is anchoring the ovary to the uterus. That is going to be ovarian ligament. Okay, understood? So we have a uterus, we have a cervix, and we have a vagina. This is uterine cavity, and then this is the internal loss. This is the external loss. Okay, internal loss of the cervix and external loss of the cervix. Okay, and the next is, if if you see this part, that is the vagina, that is the cervix which is lying above the vagina is the supravaginal part, and the cervix which is lying into the vagina is the vaginal part of the cervix. Okay, right? Next, if you see to the tubal anatomy, it is going to be fimbria. Next, then comes ampulla, then comes infundibulum, then comes isthmus, and finally it is going to be interstitium, which is found inside the uterine wall. Okay, so ampulla is the place where there is going to be fertilization, and ampulla is the most common site of what? Very good, ectopic pregnancy. Okay, now what are the supports? Okay, supports, if we see, it is going to be three levels, level 1, 2 and 3. Okay, level 1, it is going to be uterosacral ligaments and cardinal ligament. Okay, see, this is going to be the ligaments of the uterus and the cervix. Okay, here, if you imagine, this is going to be anterior, this is going to be posterior. Okay, so what happens is, in anterior, there will be pubic symphysis. Okay, then posterior will be sacrum. Okay, now what happens is, the first, that is, this is going to be bladder or the urethra. Next comes the vagina, next opening, and the third opening is going to be the rectum. Understood? So here, any ligament, that is the ligament which is in the side like a fan, it is called as cardinal ligament, or otherwise it is called as Meckenroth's. Okay, it is called as Meckenroth's ligament or cardinal ligament. That is like a fan in the side. Okay, and then the one before is going to be pubocervical ligament. Pubocervical ligament. Okay, that is from the pubic symphysis to the cervix. That is pubocervical ligament. And the one behind, that is from the uterus to the sacrum, is what is called as uterosacral ligament. Understood? So these are the primary ligaments that are actually there, which is anchoring the uterus. But there are other ligaments which are additionally present, but they don't provide much of a support. Like, it is going to be round ligament, broad ligament, and ovarian ligament, and infundibulopelvic ligament. See, this ovarian ligament and infundibulopelvic ligament are anchoring the ovaries. Okay, see, this ovarian ligament is attaching the uterus to the ovary, and infundibulopelvic ligament is the ligament which is attaching the ovary to the lateral pelvic wall. You understand? And round ligament is the one which is actually attaching itself to the cornua of the uterus, and it is actually going and mixing up to the mons pubis. Mons pubis is in the perineum. Understood? Yes. So these are the other ligaments that are actually present in the pelvis, pelvic cavity. Okay. These ligaments are divided into three levels of support. So the level 1 support will be uterosacral ligaments and cardinal ligament. Level 2 support is going to be facial support, fascia. Okay, that is fascia, um, pelvic fascia, and then fascia over the arcus tendinous. Okay, and then level 3 is going to be levator ani muscles, which is supporting the lower one third of the vagina. Okay, levator ani muscle. Levator ani muscle is the one which is going to be here, that is going to combine with the perineal body. Understood? So if you see, that is cardinal ligaments will be from the side here, uterosacral ligaments will be from the side here. Okay, and then comes only facial support in the level 2, and finally level 3, once again it is going to be levator ani support. Understood? Okay. So what are the muscles? Now we saw the ligaments. Now what are the muscles of the perineum? Muscles is divided into superficial muscles and deep muscles. So you just have to understand there is going to be two transverse perineae. One is superficial transverse, one is deep transverse perineae. Okay. Apart from that, in superficial muscles, there is going to be ischiocavernosus and bulbospongiosus. Okay. And deep, there is going to be additionally urethral sphincter. So all these pelvic muscles will come and join together in a place called the perineal body. Okay, this is the perineal body. Okay, so this perineal body will be found in the center, and this perineal body will have lots of muscles. So what are the muscles you know of? One is superficial transverse perineae, one is deep transverse perineae. Apart from that, there will be bulbospongiosus, and additionally there will be external anal sphincter and levator ani. Okay, superficial deep transverse perineae and bulbospongiosis. And apart from that, anal sphincter is also getting involved, and also levator ani is involved. Okay, so what is levator ani? Levator ani is these three muscles: iliococcygeus, pubococcygeus, and puborectalis. Okay, usually in UG and all, they generally say iliococcygeus, ischiococcygis, pubococcygeus. No, it's iliococcygeus, pubococcygeus, and puborectalis. Okay, because ischium is not actively involved in forming the pelvis. Okay, so ischium is not actively involved. So iliococcygeus, pubococcygeus, and finally it's going to be puborectalis. That is, where is puborectalis here? So it should be supposedly like this, puborectalis, because from the pubes to the rectum. You understand? Pubovaginalis is over the vagina. Here, puborectalis. See, whatever I have said, this is puborectalis. You understand? Okay. Yes. Good. So coming on to the perineum. Perineum has got two labia majora, two labia minora, and then this is the clitoris. Okay, and this is the fossa. That is, the end is called as the fossa. And mons pubis is the pelvic fatty area that is found over the labia majora. Yes. Now we have got um, two glands, that is Bartholin glands and Skene's glands. So Bartholin glands is the most common gland which can produce cysts. Okay, Bartholin glands are racemose type glands which are found within the labial tissue, and it is giving rise to, whereas these glands are found at 4 o'clock and 8 o'clock positions. Okay, 4 o'clock and 8 o'clock position, and the ducts are going to open. Okay, the ducts are 2 centimeter long, and they open into the vaginal orifice superficial to the hymen, that is just near the labia minora. Okay, between the labia and minora, it will open in 4 o'clock and 8 o'clock position. Okay, that is not exact, that is, it is said like anterior, that is anterior 2/3 and posterior 1/3. That is the position where the, yes, so there will be a swelling there. So that is what is called as Bartholin cyst. Understood? Next is going to be Skene's glands. Skene's glands is similar to that of, that is, Skene's glands is a paraurethral gland. It is similar to prostate in male. Okay, it is opening near the external urethral meatus. Understood? So next important structure in the pelvis is going to be ureter. Ureter is going to cross the major pelvic structures, that is arteries, and it is going to lie very close to the vagina. It is going to lie very close to the cervix, and then it will come and insert itself into the bladder. Understood? So in all these areas, the ureter can get damaged because it is going to lie very close to the vagina, very close to the cervix, and then it comes and gets itself entering into the bladder. Okay. And the important landmark is it is crossing the uterine vessels. Where is it crossing the uterine vessels? In the broad ligament. In the broad ligament, it is crossing the uterine vessels. And what? I'm sorry. In the broad ligament, it is crossing the uterine vessels. Okay. How is it crossing? It is water under the bridge. Water under the bridge means that is uterine vessels will go up. Uterine vessels, that is uterine artery will be up, and ureter will be down. Okay. Uterine artery is the bridge. Okay. And beneath will be the water. Understood? Ureter. Okay. So that is one of the important landmarks where, or in this place, that is when ureter artery, that is sorry, uterine artery is clamped. In that point, ureter can be damaged. Okay. And also it is going to lie very close to the anterior vaginal wall, and it is going to lie very close to the um, what to say, the cervix in the cardinal ligament. Okay. So what happens in these two places also, it can get damaged. Understood? So the points where the ureter can be damaged, anywhere you clamp in the broad ligament, in the uterine artery ligate manamodu, or in the cardinal ligament, it is getting damaged, or in the anterior part of the vagina, it can be damaged. Anywhere it can be damaged. So you have to be very careful when you are doing a hysterectomy. Okay. Internal iliac artery. This internal iliac artery, because iliac arteries are the major supplies to the pelvic tissues. Okay, you remember this mnemonic for knowing what are the divisions of, that is what are the branches of arteries. Okay, so here it is Soumi is very good on pills. That means anterior, it is SOUMI BNG. Okay, superior vesicle, obturator, uterine, middle rectal, and vaginal. The next is going to be gluteal, inferior gluteal. Actually, internal pudendal is missed. Okay, internal pudendal, vaginal, and inferior gluteal. Okay, so this is anterior division. Okay, posterior division is pils. That is posteriorly there will be iliolumbar, lateral sacral, and uh, superior gluteal. Yes. Okay, iliolumbar, lateral sacral, and superior gluteal. Understood? This is posterior. So, and uterine artery is a branch of anterior division of internal iliac. Understood? So, the blood supply to the perineum or the blood supply to the vulva, it's mostly by the pudendal artery and perineal arteries coming from the femoral vessels and internal pudendal vessel. Okay? And we have lymph nodes. Lymph nodes is obturator lymph node, which is the sentinel node for cervix. Okay, obturator lymph node is the sentinel node for the cervix. Okay, and generally ovary, it is going to be para-aortic, because all the that is all the that is ovary and testis both always drain into the aortic lymph nodes. That you have to remember. Okay, cervix is going to be obturator. Rest others, all the external ones are all draining into the inguinal lymph nodes. Okay. And uterus, see, uterus is draining into the internal iliac lymph nodes. See, why do we know? We have to know about the lymph nodes is whenever you do the surgery for particular reason, that is, for example, carcinoma, because lymph nodes are very important for metastasis, correct? So, whenever you do a surgery for a carcinoma, you should know what lymph node it is draining into. Only then you can do a dissection of that particular lymph node. Okay. So, if you have a uterine, CA endometrium, which lymph nodes you Dissect. Internal iliac and para-aortic. Okay, but para-aortic is very deep. So at least internal iliac we have to dissect. Understood? Good. And innervation is by various plexus. Okay. Mm, from the lumbar T12 up till, from T12 involving all the lumbar, all the sacrum, and finally till S3, S5. Okay. It is going to be supplying. Okay. Yes. So various plexuses are there. Lumbar plexus, superior hypogastric, inferior hypogastric, pelvic Frankenhauser plexus, ovarian plexus, all these are going to be lying just near to the organs. Okay. All these are going to supply. So location of the Bartholin gland is very good. Yes. Function of inhibin. Okay. So we all know that hypothalamus is going to have, it is going to give GnRH that is going to act on pituitary and it is going to give FSH and LH, correct? So this FSH will be acting on the granulosa cells and it will produce estrogen from androgens because androgen by the action of aromatase it is going to gives rise to estrogen, correct? So this FSH, that is this FSH and LH as they are acting in along with producing E2, it also produces inhibin. This inhibin is going to have a negative feedback effect on FSH. Understood? Two-cell, two-gonadotrophin theory is applicable in ovary as well as in testis. Okay, that means in ovary there is going to be two cells. One is theca cells and one is granulosa cell. And in testis there is going to be two cells, Sertoli cells and Leydig cells. Okay, so what happens is granulosa cell, what is acting? FSH is acting. And in theca cell, what is acting? LH is acting. Okay, so a similar way in Sertoli cell, FSH is acting, and this Sertoli will give rise to yes, that means spermatogenesis. Okay, whereas LH is going to act on Leydig cells LL and it is going to give rise to testosterone. Understood? So along with all these, there is going to be production of inhibin also. This inhibin is going to have a negative effect on yes. Okay, right. And this I think we already know how this FSH and LH bring about the changes. So in the first half of the cycle, that is called as the proliferative phase in the endometrium. The second is going to be secretory phase. So here estrogen is playing a role and here progesterone is playing a role. Okay. And when both estrogen and progesterone drops, it will result in menstruation. Yes. See, there is a low E2 and progesterone. This results in menstruation. So what happens is FSH, that is FSH will once again start to rise and this will give rise to E2 production. So this E2 will act on the endometrium to cause proliferation. Okay. So as the E2 keeps increasing, increased E2 will result in LH surge, correct? This LH surge will result in ovulation. This ovulation will result in corpus luteum formation. This corpus luteum will give rise to progesterone. So this progesterone, what it will do is it will make the endometrium secretory. Understood? Okay. So function of inhibin is very good. Inhibits FSH. Now let's go on with the development. See, in development, we have got gonadal development, we have got genital development, and we have got that is genital development that is external genitalia development, and otherwise there is another development which is behavioral development. Behavioral development is even though the sexual identity is something, but they identify themselves as a different individual. That is behavioral differentiation. Okay, so genetic sex, gonadal sex, and genital sex. Genetic sex is either XX or XY. Gonadal sex is either ovary or testis. Genital sex is either labia or scrotum and penis. Okay, yes, Good. So what is the determining factor? Y chromosome is the determining factor. Okay. If Y chromosome is present, definitely testis. If Y chromosome is absent, the gonads are going to become as ovaries. You understand? So there is going to be presence of SRY gene on this Y chromosome and anti-Mullerian hormone. So both these things are going to convert the undifferentiated gonad to become the testis. Understood? So from testis, there is going to be Sertoli cells and Leydig cells. Correct? In testis, Sertoli cells will result in sperm production and Leydig cells will give you testosterone. So this testosterone, what happens is, this Sertoli cells also produce AMH. AMH means anti-Mullerian hormone. Now you have to understand the Mullerian duct and Wolffian duct. Okay. Maybe I will write it here. So here it is going to be Mullerian duct and here it is going to be Wolffian. Okay. So what happens is, or it is going to be paramesonephric duct or mesonephric duct. Okay. This is what I would have explained in the last detailed explaining, the class where I explained it detailedly. This is going to be in females and this is going to be in males. Okay. So in males it is wolf and mesoid. Okay, so that is Wolffian duct and mesonephric duct, whereas in female it is going to be Mullerian or Mullai and paramesonephric duct. You understand? So what happens is, there is a factor called AMH, that is anti-Mullerian hormone. Anti-Mullerian hormone is present in males to prevent the production of Mullerian duct. You understand? Because Mullerian duct should not be there in males, correct? Okay. So testosterone is going to produce dihydrotestosterone and it is going to develop the male external genitalia. And AMH is going to prevent Mullerian duct development. If nothing is going to be there, the baby is going to develop as a female. Okay. So there will be Mullerian duct development and female external genitalia. Yes. So this is what is actually being said here. Okay, by fifth to sixth week, what happens is the testis AMH will be produced. This AMH is going to stop the Mullerian hormones from developing. And if there is absence of AMH, what happens? There will be female genital organs also will be present. So this is a true hermaphrodite. See, there is going to be both testis as well as female genital organs. Uterus, vagina and everything, because absence of AMH means Mullerian duct will develop. If Mullerian duct develops, there is going to be presence of uterus and vagina. You understand? Even though testis is present. Okay, right. So now what happens is, if this testosterone or dihydrotestosterone is absent, then it will result in female external genitalia. Correct? You get the point? No? See, that is, Y chromosome is responsible for testis or ovary. Okay. Once if testis comes, testosterone is responsible for male genitalia, male external genitalia. And anti-Mullerian hormone is responsible for internal genitalia. That is Mullerian hormone, anti-Mullerian hormone. That means Mullerian duct won't develop. Okay. You understand? Mullerian duct, no development. Understood? Yes. See, in XY, testis is present. If the testis is present and AMH is present, everything is male. If testis is present, testosterone is present internally, that is testosterone is present in external genitalia will be male only. Internally made, it will be male because there is nothing to develop in a male inside. But Mullerian structures, that is uterus and vagina, will be present because there is no AMH. You understand? And whereas here both testosterone is here testosterone is absent and anti-Mullerian hormone is present. That means since testosterone is not there, it will develop into a female external genitalia. You understand? Okay. So if it is going to be an XX, clearly there is going to be ovary. If ovaries is if in ovaries, if there is going to be no androgens, it is going to be everything is going to be female. But if androgens are going to be present, there will be masculinization of the external genitalia because androgens like testosterone is what is going to create male genitalia. You understand? That is why in PCOS patients, PCOS androgens are more. Correct? Instead of that is androgen production is more. That is why they develop hair, facial hair. Okay. Sometimes if the androgen is very high, they can also result in clitoromegaly. Okay. So how will the ovary and uterus develops? It is from the Mullerian duct. Okay. From the Mullerian duct only, the internal genital organs of female develops. Ovary is developing from the gonadal ridge and germ cells will become the oocytes. The Mullerian ducts, what happens? Two Mullerian ducts are going to be present. Yes, see, the two Mullerian ducts are going to be present, one on the right, one on the left, and they will fuse in between, and this fused part will give rise to the uterus. Okay, and then there is going to be Mullerian tubercle and urogenital sinus. So these two are going to give rise to upper and the lower part of the vagina. You understand? The unfused portion is going to be the fallopian tube. Okay. Yes. So any problem in the development, that is in the process of development, is going to result in ambiguous genitalia. Okay. Ambiguous genitalia can be male pseudohermaphrodite, female pseudohermaphrodite, or two hermaphrodite. Okay. Two hermaphrodite means there is both the presence of male features and female features. Okay. So what is going to be the male and female pseudohermaphrodite? In male pseudohermaphrodite means what happens is inadequate testosterone, that is the problem. That is, the person is a male only, but since there is less amount of testosterone, where and all it will be there, that is either there is a 5 alpha reductase insufficiency, that is partial androgen insufficiency syndrome. Okay. Or because and also in complete, that is inadequate testosterone receptors as seen in androgen insensitivity syndrome, AIS. In all these conditions, what happens is testosterone will not be functioning properly. So actually the patient is a male only, but he will have female characteristics. That is, maybe female genitalia might be there. Okay, that is what is called as male pseudohermaphrodite. It is the ulta for the female pseudohermaphrodite. The person is a female but will have male features. You understand? Where and all that will happen when you have increased androgens, correct? If you have increased androgens, what will happen? In a female, this androgens will create male characters. That is female pseudohermaphrodite. Okay? You get it? Yes. Um, this androgen insensitivity syndrome that we saw, androgen insensitivity syndrome means in male, androgens are produced. Okay? But it is insensitive. That is, it is not able to perform its function because of receptor insufficiency. Okay, because of some receptor problem. So what happens is this androgen, since it is not performing its function, it is going to result in, it is going to present as a female. You understand? So that is called as testicular feminization syndrome. Understood? If it is partial, okay, if it is partially insensitive, it is called as Riefenstein syndrome. Understood? You understand? Okay. So, what makes a male person to present as male? What hormone? Very good. Testosterone is what is going to say whether the person is a male. If you look at him, if you see a male features, it is because of testosterone. Okay. Inside, sometimes uterus and vagina can be there that we don't know. That is because of anti-Mullerian hormone. Okay. Yes. Right. There is another gender identity disorders associated with abnormal sex chromosomes. Like for example, XXY is called as Klinefelter's. Turner syndrome, XO. Okay. All these are abnormal sex chromosomes. That is genetically the sex is a problem. Genetic sex is a problem. Okay. You understand? Okay. So stigmata in Turner syndrome, what will the patient present as? Short stature. Short stature will be there, and then webbed neck. There will be chest. If you see, there will be white spaced nipples. Okay, no axillary hair, and then cardiac anomalies will be there. An absent breast development because it is XO ma. XO if it is there, the ovary itself is a problem. Okay, the ovary is a problem. So there will be no E2. E2 also will be very less and progesterone also will not be present much. You understand? So since estrogen is not there, there will be no pubic hair development. There will be no breast development. Nothing will be there. You understand? Okay. And whereas this is Klinefelter's. Klinefelter's is XXY. Okay, so they will have a extra feminization feature. So that is why breast development will be there. Okay, less developed testis. The patient will be tall and looking very handsome because there will be no facial hair. You understand? Okay. So this is regarding the sexual development. Now the problems of Mullerian duct development. Okay, Mullerian duct development. If there is going to be a problem within the development of the Mullerian duct. Okay, see, as I already said, two Mullerian ducts together come and fuse in between to form the uterus. A Mullerian tubercle and urogenital sinus will form the vagina. Correct? Okay. So, these two unfused parts will be the fallopian tubes. You understand? So, what happens? The formation, fusion, and once it fuses, this fused parts should resolve to form a cavity. So, septal resorption. You understand? So in any of these part, if this is not happening, then it will result in anomaly. Okay. So either development ஆகலனாலும் abnormality, fuse ஆகலனாலும் abnormality, the fuse ஆனது recanalize ஆகலனாலும் abnormality. Okay. So this will result in Mullerian duct anomalies. So what happens is formation. Anything is agenesis. Okay. And then only one side it is formed. Unicornus. Both the sides it is forming, but it is not uniting. So it is actually giving rise to two uterus. Uterus didelphys. Okay. It is actually uniting, but it is partially united. Okay. Bicornuate. Hmm? And then even if it is united, the septum in between has not resolved. So it is septum. Sometimes the uniconvate uterus, there can be a tiny horn. That is rudimentary horn. Okay. This is actually the classification. This, I think you just have to understand the, um, what to say, the major classifications alone. Like first is going to be agenesis. Formation itself is a problem. Developmental itself is a problem. Hypoplasia or agenesis. Second is going to be unicornate. Only one side it is forming. Third is going to be didelphys. Why I'm explaining this is you have questions in this. Okay. Didelphys is both sides it is forming. Okay. Fourth is going to be even both the sides are forming, it is partially united. Understood? Fifth is going to be septate. That is, it is formed, but center there is a division. Okay. Sixth is going to be arcuate. Arcuate is a dip. Okay. Last is going to be drug related. Diethyl sylvestrol related, which is T-shaped uterus. Understood? Now, answer. Very good. Klinefelter's. Female pseudohermaphrodite. All are true. Female pseudohermaphrodite na female presenting as a male. What is true? See, the answer is, which is not true. Ovaries and uterus is not absent. That is not true because it's a female. Already I've said XX இருக்கும், ovaries uterus absent இருக்கும். ஆனா she will present as a male. See? Okay. இந்த mullerian inhibiting substance is not producedங்கிறது வந்து பாத்தீங்கன்னா even females will be having AMH, anti-mullerian hormone. Okay, this is actually present to some extent that this AMH is actually used in the diagnosis of what to say ovarian reserve in infertility. It is not that AMH is completely absent in females. It is actually present to some extent. Okay, so the answer என்னன்னா the which is not true அப்படின்னா ovaries and uterus are absent. No, the patient will have ovaries and uterus. Okay, what is this? What type of uterus? Very good. Okay, so what is the result? Why does it result? Very good. Yes, yes, good. Unicornuate uterus, what is the class? ஒன்னு hypoplasia or agenesis, ரெண்டாவது unicornuate, மூணாவது didelphys, நாலாவது bicornuate. Sorry, bicornuate. Correcta? It is 2. I think we are finished with all the basics and next we'll move on to amenorrhea, menopause and puberty. Okay, next session.